fix Facebook, so hold on just a moment.
All right. Good morning. Happy Monday. This is week 2. So you are a quarter of the way done. Look at that, guys. Look at that. All right. So over the weekend, you had 2 chapters of homework. You had chapters 2 and 3. Does anybody have any questions? Anybody struggle with any concepts? Do you need me to explain anything to you? Okay, so this is a very, very common question. When you take the exam and you pass it, you become a CNA. That C just stands for certified. All that means is that some third party verified your skills and put you on a registry, okay? So it means you're tested, you're proven. Now, if you don't, the only place you have to be a CNA to work is a nursing home or home care if you don't have anything else. That's it. You don't have to be a CNA to work in a hospital. You don't have to be a CNA to work in assisted living. You don't have to be a CNA to work in a doctor's office or mental health or any other setting. But they can't call you a CNA if you're not tested, if you're not certified. So you have to be certified to work in a nursing home. But if you work anywhere else and you don't have that certification, because it's not required, they can't call you a CNA. They would call you something else. An NA, an aide, a nurse, nurse tech, a patient care tech, a patient care assistant, a personal care attendant. They can call you anything. And we call it alphabet soup because none of those letters mean anything. All it means is you're there to help somebody who needs help with personal skills. Not nursing, personal skills. Okay. So if you're helping your neighbor and you're doing these tasks that we're learning how to do, that's not CNA. Those tasks are not CNA. Those are just personal care. You don't have to be a CNA to help your kid brush his teeth, right? It's just body maintenance. So it's important to understand what a CNA is and what they aren't. CNAs are certified. Does that help you? Does that make sense?
So in the yellow book, the rules for NAs, they are they the same for us?
So, and yes, okay. I understand where you're getting. They can't call it CNA until you're tested. So in your yellow book, you're going to see nurse aide because you haven't been tested yet. They can't put that C in front of it. Okay, good. So last Tuesday, I did that game show. And this is something that I've got to do a lesson on this and get it up on YouTube for people to understand this. If you look at the test plan, and the test plan is published, and the test plan is the same for every single state, the written test plan. If you look at the category basic nursing care provided by the nurse aide, if you look at that category, that is not where feeding, dressing, grooming, toileting, that's not where all of those tasks are. They're not under basic nursing care. They are under promotion of health and function. So that tells us that those tasks that we think make us a CNA, actually, that's not the CNA part of what we do. Recognizing and responding to emergencies and changes in condition is what makes us a CNA. That's the nurse aide part. because anybody can help somebody brush their teeth. You don't have to be certified for that. What you do have to be certified for is to understand what things that you might see while you're brushing teeth and what would need to be reported to the nurse. Or to recognize an emergency because these patients are in high risk areas. Does that make sense? Okay. So this is, it's really, good morning. It's really confusing to people. It's confusing to the healthcare system, but it's really confusing to people because we tend to think that what we do makes us a CNA. But it's actually not really what we do, it's what we know. That's the difference. Anybody can do, it's what you know that's going to make you certified. Good? Does that make sense? Good? Okay. All right, so let me get your scores for chapters 2 and 3. When I call your name, either tell me how many you missed or tell me what your score is. And you can find your score by looking on page 201 at the very bottom down here. It'll tell you how many you missed and what your score was. Sheila, on chapter 2? And what about chapter 3? None? Okay, very good. Jaden? Thank you. Ariana?
I wasn't able to come into the classrooms there. And
Yep.
I also couldn't find it online. I looked through the YouTube videos and none of them.
Okay, it's, yeah, you have to go to the playlist and click on classroom live stream. Yeah. Or just go directly to FLCNA training. It's right there on the screen. That's the easiest way. And that's on your syllabus way up here at the top, FLCNA training. You're welcome. Oops. Okay, Audrey. Do you have chapter 1 for me?
I got 100 on that.
Thank you. Ethan.
95
Okay.
and 90.
Thank you. Ashley.
195.
Thank you. Emily. Mercedes. Martina.
95 on both.
Thank you. Susie. Amanda.
I couldn't find the video either.
Okay, no problem. If you go, again, if you look at the top of the syllabus, FLCNA training, the video is right there in the middle of the page. Brittany. Did you guys get our wrap-up emails?
I got the first one. I didn't get the second one.
I
Okay.
didn't get any of them.
Okay. After class today, please make sure you check in with Jake and let him know which wrap-up emails you're missing, so he can make sure that we get those out to you, because those also have the link to the video. Okay, yeah, make sure you check in with Jake and he'll be happy to help you. Madison and Rain, were you able to get to those?
I didn't do the last test, but I did do the first two.
Oh.
I got
100
100.
on both? Very good. Very good. All right. Let me talk really quickly about something that was mentioned in your homework reading that's really confusing for people, and it's Maslow's hierarchy. Those of you who are going on for more advanced medical anything, you're going to know all about Maslow. You're going to have to study him for months. So I'm going to give you a 3-minute version of Maslow, okay? And what it means is that you have to have basic needs met before you can concentrate on anything else. Makes sense. If I don't have oxygen and I can't breathe, do you think I'm working on my thesis up here?
No.
No, I'm worried about breathing, oxygen, survival, right? If I don't have enough food to eat, am I worried about, I don't know, what my next car is going to be? No, I'm worried about how am I going to not starve? Does that make sense? Right? So if our basic needs aren't met, nothing else matters. Now, once we meet those basic needs, we're going to move up a level. And then we have to think about safety and security. So this is, do I have a safe place to be? Do I have a home or a shelter of some sort? Am I out of the elements? Do I fear for my life? If I'm living in the middle of a war zone, I'm probably not thinking about my next car, right? I can't think about my next car because I don't even know if I'm going to make it out my front door today. So safety and security. Then the next step up is love and belonging. We all have to feel cared about. You have to know that somebody in this world cares whether you live or die. Everybody has to have that assurance to be able to advance beyond that. Does that make sense? Okay. And then when we reach our fullest potential, when we're firing on all 8 cylinders, everything is going well, and I'm worried about what my next car is going to be, that means that all of my other needs have been met. Make sense? Okay. So Maslow's the one that really kind of put this in a pyramid and said, this is important because as healthcare workers, we're not really thinking about their higher level goals. We don't really care. I don't care what car you buy. Doesn't impact me at all. So because we don't care, we don't look at any of it. And yet it's important for us to understand that this is going to impact how we relate to our patients. Because if your patient is struggling to breathe because they have COPD, if they can't get enough oxygen in, do they care what you have to say? No. Do they care that you want to give them a shower? No. That's the furthest thing from their mind. And yet we get so focused on our tasks. Well, you're on my shower list today. If we don't understand the level of needs, if your patient is focused down here on survival, no matter what you want them to do, if it's not survival focused, it's not going to happen, no matter how much you think it should. Does that make sense? Good. It's important that we understand that because you're going to have a lot of your patients throughout your career that are going to tell you no. No, I don't want a shower. No, I don't want to go for a walk. No, I don't want lunch. Leave me alone. And that's because they're just focusing on their survival tasks at the moment. And we need to do whatever we can do to help them meet that need. It's always about the patient. That's what Maslow is trying to bring us back to. Does that make sense? You will have a question on the state exam about Maslow. It may not be direct. It may not ask you, which of the following is a safety and security need according to Maslow's hierarchy. They're not going to ask you anything concrete like that. Although if you go on, you'll get lots of questions like that. This is going to be more about recognizing that the patient and you are not on the same wavelength. Okay. Does that make sense? Okay. All right. Okay, so we're going to get into a brief review about everything that we learned last week. This is going to cover the principles that we have learned as well as the skills that we covered. So we're going to do this pretty quickly. You should be able to shout these out pretty quick at this point. But remember that if you need a review, the very beginning of each class is where you're going to find that information. Your class worksheets that we hand out at the end of each class, if you complete those when we hand them out and keep them all together, that actually becomes a study booklet for the state exam. And it has all of these principles as part of the study packet. Okay? All right. So how do we know what to do with each patient?
Yep, ma'am.
We follow the care plan. That's right. What do we know about the care plan? Why do we have to follow the care plan? What do we know about it?
The needs for the patient.
For which all patients?
No, not all patients, that particular patient.
That particular patient. So this guy's care plan, is it going to apply to anybody else?
No.
No, it's only for him. So that means every care plan that we look at is probably going to be a little different. That's right. Very good. Very, very good. So as a CNA, we're going to follow that care plan, the whole care plan, and
Nothing but a care plan.
that means that we cannot change that care plan, and your brain will try to change it. I guarantee it. Your brain will put a but at the end of a sentence. But what if? Turn your brain off. That is the number one error that is made on the written test. People read into a question and they put something in that does not exist. The question stands alone. Make sense? Okay. How many of you guys know someone who has ever been in a car accident? Anybody know someone who's ever been in a car accident? Yeah. Yeah. So, if you know somebody who's ever been in the car accident, did they all have the exact same injuries?
No.
But it was the same problem. They all had a car accident. How come they all didn't have the same injuries?
It depends how the body wounded by a car accident, like the body parts of it.
Okay, so it depends on the level of injury. It depends on what kind of a car accident. Are we talking about a fender bender in a parking lot where you're barely moving? Or are you talking about a head-on collision at 120 miles an hour? Right, those are two big, they're both car accidents though, aren't they? Right? So we have to think of healthcare the same way. Just because somebody has a condition, it's just like it's like saying they were in a car accident. It means nothing. It means, yes, something happened, but that doesn't give us any information. So if I tell you that this patient has diabetes, that's like saying they were in a car accident. Doesn't give you the information you need. How serious is it? What do I need to know about that patient to help care for them? And that's what that care plan is all about. So if you change anything in your mind, you've changed the whole thing. So if I say, if I'm writing a care plan, I say this patient was in a car accident, they have a broken arm. And your brain goes, yeah, but what if they went through the windshield? That has nothing to do with the scenario I gave you. And yet that's what we do on the written test. We put that but in there. But what if? But what if? So when your brain tries to do that, when your brain says, but what if, the next part of that is, but what if they went through a windshield? It doesn't matter. It doesn't apply to this person. Okay. Good. That is the best piece of advice I can give you for passing the written test, because we do it intuitively. We always add something into a question, and that changes the entire question. Good? Make sense? Don't add anything in. So we follow the care plan, the whole care plan, and nothing but that care plan. While we're following that care plan, what are we supposed to be doing?
Observations.
Making observations. Yeah, this is what we see, what we hear, what we smell, what we feel. Don't taste. Please don't taste. But the other senses, very important. If you smell something that makes you go, that's weird, it needs to be reported. If the skin is warmer in one area than another, that's an observation that needs to be reported. Warmth means inflammation. If you notice that vital signs are not in the normal range, it needs to be reported. Anything that you observe, if your brain goes, huh, it needs to be reported. And then who do we report those observations to?
The RN.
The nurse, absolutely. And it's up to the nurse to go reassess that patient and figure out what we're going to do about that piece of information. Now, I wish I could tell you that all nurses are good. Boy, do I wish I could tell you that. We had an incident just this past weekend or a couple days ago where a NICU nurse, this is a nurse that should have known better. NICU, neonatal intensive, these are the most vulnerable creatures that we care for. And she walked away from the bed with a piece of equipment in her pocket that was attached to the infant, pulled the infant off the bed, infant hit their head, the infant is now dead.
That's not good.
I wish I could tell you that all nurses are good. They're not. So if you report something that you notice, no matter how minor it seems to you, and that nurse does not act, does not acknowledge that they got that information, if you have concerns that they're not listening to you, you can go up your chain of command. So you would go to the nursing supervisor and you would tell them, listen, I was caring for this patient. She has right-sided facial drooping. Her right arm is not moving at all, and her speech is slurred. And I told the nurse, and nothing is being done. That nurse supervisor will get involved. And you've probably just saved that patient's life. Because we only have 90 minutes from the time stroke symptoms start until we can possibly stop the damage. So if you go to the nurse and say, listen, this is what I'm seeing, and nothing is happening, you can go up your chain of command. Okay? Like I said, I wish I could say they're all good. They're not. So when we're doing skills, every skill that we do, once we find out what the care plan wants us to do, every skill we do is going to start with something called the opening. What does every opening start with?
Knock.
A knock. Now remember, for the test, your brain is going to go completely blank. So you need to remember this. Every skill starts with the opening. Every opening starts with
The knock.
a knock. And if you can remember that, that will at least get you here. And then you should hear me do this enough that you should be able to repeat what I say. How many of you guys have ever watched a movie so much you've learned the lines? I got several movies. You put those movies on and I will talk right along with the movie. I know all the lines, all the parts, right? I know it all. And I will. I can't help myself. I will just chatter along with the movie. If you listen to me enough, that's what you're going to end up doing. As long as you can get here, you'll go with, hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Of course, use your name. Don't use Patty. All right. So every skill starts with the opening. Every opening starts with a knock. Who are we going to greet?
Patient.
Now I want time out here for a second. Yes, this is important. This is what they're grading you on. This is what's on the checklist. We're going to greet the patient. Absolutely, 100%. But if there's family in the room, don't exclude them. That patient is part of a unit. And if the unit is there, don't ignore them because you're actually ignoring part of the patient. So if I walk into a room and there's a bunch of family members standing around, I have been in rooms where there's 20 family members that are surrounding the bed because they're all freaked out over whatever's happening to auntie, right? And there are some families that are very, very close, very close. My mother goes into the hospital, everybody is there. It's like all hands on deck. We're all there. Some families are very close. Some patients will be alone for the entirety of their stay. Every family is a little bit different. But if I walk in and I see an entire family around that bed, I know this patient actually has a better than average chance of beating whatever it is that brought them in. Regardless of what I do, regardless of what medicine does, they have a better than average chance. Do you know why? Family, but it goes right back to Maslow, believe it or not. Remember that love and acceptance, love and belonging. If you feel a sense of belonging, if you feel close ties, You are way further up on Maslow's hierarchy, and that actually gives you more resources to draw from, and you generally have a better outcome. Isn't that amazing? So if I walk in and I see the whole family, I actually get giddy because I know that this person might actually beat whatever's trying to kill them. So I'm going to make sure I include that family. Good morning, Mrs. Jones. Hi, family. I'm so excited to see all of you here. Don't treat them like they're an inconvenience or they're in your way. They're a big part of her healing journey. Good? Good? All right. Incidentally, Americans. I am an American. I am born and bred. I am a Floridian. We're pretty rare. Born here, lived my whole life here. But we tend to be a bit short-sighted when it comes to cultural differences. We tend to think that everybody is like us, and that couldn't be further from the truth. But here's the thing that I need you to understand. In a lot of cultures, more cultures than American, when somebody goes to a facility, the family is the one that does your job. Families stay at the facility with their loved ones. They do the bathing. They do the feeding. They do the dressing and the grooming. They provide the hands-on care for the patient. Remember, that's not what makes you a CNA. Recognizing and responding to emergencies is what makes you the CNA. Because when an emergency happens, that family is going to go, what do we do now? Where a CNA is expected to know, I know what to do now. Okay, so don't just try to dismiss the families, because culturally they play a much bigger role in the care of this patient than you are going to allow them to, unfortunately. Does that make sense? Good. Don't make the mistake of thinking American culture is all culture. If the family wants to be involved, I'll bring them the toothbrush, no problem. Okay, how are we going to know that we have the right person to work with here?
Identify the patient.
What's that?
Identify the patient.
How do we identify the patient?
By their name.
By name, sure. Sure, absolutely. If I walk in and I say, good morning, Matilda, how are you? What are you going to say?
Sorry, that's not me.
Yeah, because you don't want what I've got in store for Matilda, do you? You don't know what it is, but you're pretty sure you don't want it. Okay. Now, of course, this changes if your patient has dementia, if your patient has a stroke and can't speak. This will change. But that would have been determined when the nurse did her assessment, and she would have put on the care plan how to identify this patient. That's not your problem to solve. You're simply going to follow the care plan. Very good. You guys, are you starting to see how this whole thing goes together? Are you starting to see that if you've made a decision, you took a wrong turn somewhere? Okay. Tisha says, thank you so much. I passed on my first try by watching your videos. Congratulations. Great job. Oh, I'm super proud. Thank you so much. All right. So what do they need to know about us?
Introduce themselves and their title.
Yeah, name and title. So hi, I'm Patty, your CNA today. Not, hey.
They don't know you.
Hey is not an introduction. They need to know your name and title. On another note, when you go to work, you're going to be given an ID badge, and it will have a picture on it. It will have your first name and your last initial. We don't put last names on most of the time anymore. First name, last initial. Make sure that that badge is always facing out. If you're going to put your hands on somebody, they have the right to know who you are and what you mean to do with those hands. Now, we're seeing that play out in a political aspect right now. People are putting their hands on other people without identifying themselves, and it's causing a lot of chaos. Because remember that part of your individuality is being able to determine who gets to put their hands on you and who doesn't. If you think it's causing chaos out there, imagine if your patient is vulnerable, how they're going to react. Does that make sense? Okay. Always make sure that your badge is visible, turned the right way. I don't know why, but this is becoming an issue out there. This is becoming an issue. Managers are spending a lot of their time writing up staff members for intentionally obscuring their badge. This is not something managers should have to spend time doing. That just tells me that those staff members aren't putting the patient first. Good? Okay. Now we have to describe the skill. What are we there for? And you can read it right off the care plan. I am here to, whatever it says. Or you can put it in your own words. I tend to put it in my own words, make it professional. But I tend to put this in words they'll understand. I need to do some exercises on your shoulder. I need to brush your teeth today. I need to help you get dressed. I need to get you out of bed and into the wheelchair. Is that okay? Right. Once we've described what we're there to do, we're going to get that all-important consent. Patients have the right to say no, and we have the obligation to listen. What do you do if a patient says no?
If we don't do it, we're just going to report to the
Report it to the nurse. Try to find out a little more information, like why. Why? That's always a good question. Nicely, why? Why don't you want to do whatever? Is this a bad time? Are you not feeling well? Because when you go to the nurse and you tell them the patient won't let me do whatever, they're going to ask you why. So go armed with that information. Once we have consent, we're going to provide some privacy by closing the curtain. And is that curtain clean?
No.
So what do we want to do about it? Wash our hands. Once we've washed our hands, we're going to go get our supplies. Simone says, good morning, Miss Patty. Are we supposed to lower the bed when we walk the patient? So Simone, we're going to get into ambulating, let me see here, next week, next Monday. But your bed should always be in the low position unless you are actively working with the patient on the bed and you need it raised to a comfortable working height for you. In this case, you're not working with the patient in the bed. So the bed should be in the low position. You're helping your patient stand up and walk. The floor should always be right where that patient left it. Okay. All right, so our cardinal rule here is do not touch the resident until your hands are clean. Great job. Okay. Glove rules. Do we wear gloves for everything all the time, no matter what? Why? Because we don't have to. But if we wear gloves all the time without thinking, what's the problem with that? Yeah, we're not thinking. That's right. We're going to end up ultimately putting this patient much more at risk, just like our sandwich did. So if we're not going to wear gloves all the time for everything, then when should we wear gloves? Okay, body fluids, personal skin, and open skin. That's right. That's right. Body fluids, non-intact skin, and personal skin. So if we're going to touch any of those three, or if there's a possibility that we might touch any of those three, we're going to wear gloves. But if we decide to wear gloves, what is the first thing those gloves should touch? So should we put our gloves on and then get our toothbrush ready?
No.
Should we put our gloves on and go get our basin of water?
No.
Should we put our gloves on and then put the privacy blanket on?
No.
We should do all of those things before we put our gloves on. That way, the first thing that those gloves touch is the patient. Okay. Now, once you've done the skill and you've gotten contaminants on your gloves, we have to be careful about what we're touching in the environment. Should we open the curtain with those gloves?
No.
Should we touch the bed controller with those gloves?
No.
Should we give the patient the call light with those gloves?
No.
Should we touch the sheet that's going to go right up next to their face with those gloves?
No.
Good. So we have to remove our gloves before we touch all of those things. That helps prevent cross-contamination. In order to remove your gloves, you're going to pull up at the cuff, pull that one off, bundle it up in this hand, and then go underneath to take the second one off. So pinch up at the cuff and then go underneath. Great job. We also learned about the barrier. We're going to use a barrier anytime we use supplies. And the whole purpose here is to create a clean area for our clean supplies. Barrier is all about clean. Table is not clean, so we'll put a barrier on it. We only want to touch supplies with clean hands, and we're not going to hold those supplies up next to our uniform. And when we do this, we want to go get that barrier first. So we've done our opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands. I now have clean hands. I can go get my supplies. But the first thing I'm going to do is grab that barrier and put it down on the table because I don't want to hold those supplies against my uniform. Good. Then once the barrier is in place, I can go get the rest of my supplies. Okay, Simone says, I have another question. My friend did the skills last Saturday. The instructor asked her, what is the input of the urine after she did the output and measurement? I don't, not being in there, I don't really understand this. I'm wondering if maybe she documented in the wrong section. That's kind of what I'm thinking, is that because on the, we're going to see this on the last skills day, 2 Mondays from now, that with this intake and output, you actually have to document on a form that has an intake section and an output section. And a lot of people document it in the wrong place. And I think that in this situation, maybe the evaluator was trying to prompt her to take a look at the form without coming right out and telling her. Now, evaluators aren't supposed to do that. They're not supposed to interfere with your test at all. Sometimes the evaluators can't quite help themselves. Yeah, I'm thinking that this was maybe an evaluator that was trying to prompt her to take a closer look. I wasn't there. I don't know. That's really kind of the only thing that I can suggest with that situation. All right. And then we have privacy blanket. Can you take that down, Jake, please? Oh. Oh, okay.
There we go.
Oh, good morning, Ree. All right. So privacy blanket. We have to remember that our perception of temperature is going to be completely different from our patients. Please keep that in mind. So when we put a privacy, or when we're doing any skill that requires our patient to be uncovered or undressed, we want to provide an extra layer of privacy. This helps protect them from all of you guys, but it doesn't do anything to protect them from me. It also doesn't do anything to keep them warm. So privacy blanket will do all of those things. So we're going to use a privacy blanket to keep the patient warm and provide privacy. We use it anytime our patient is uncovered or undressed. So remember that during the exam, your care plans are not going to tell you to use a privacy blanket. They're not going to tell you to use a barrier. They're not going to tell you to use gloves. These are all things that you have to know. So you have to know when gloves should be used and how they should be used. You have to know when a privacy blanket should be used and how it should be used. So remember that these principles that we're going over are things that you are required to know that won't be on the care plan. They're also called best nursing practices, and they're pretty much universal. All right, so when we put the blanket on, we're going to put it on over the sheet and pull that sheet down underneath. But when we do that, we don't want to snap or shake that blanket, which aerosolizes any pathogens that might be on the bed. At the end of the skill, we're going to remove our gloves before we remove the blanket because we don't want to touch that sheet that's going to go right up next to their face with those pathogen-covered gloves. All right. Linen rolls. These are all repeats. We've heard all of these before, the first three. Linens must not touch our uniform. Well, we heard that with barrier rules. You must have clean hands to get your clean linens. Same thing, heard it with barrier rules. And you don't want to snap or shake your linens. We heard that with privacy blanket. Remember that anything that is repeated is infection control, and infection control counts big. The other two we're going to skip for right now. We're going to go down to the bottom, and anything unused must be discarded. You can't save it for later. We'll cover those other two in a little bit. And then every skill ends with the closing. Always leave your patient looking better than you found them. So take a minute, look around, and make sure the environment is clean. Make sure your patient is safe. So safe means the bed needs to be in the low position and they should be in the middle of the bed, not too close to either edge. If you notice, and I'll give you the biggest culprit of this. So one of the skills, we're going to learn it on Wednesday, is side lying position. That means that we're going to turn our patient on their side, use some pillows to keep them in that position. The biggest error that's made in that skill is students will turn them on their side the right way. They'll put all the pillows in the right way. Everything looks good, but your patient's right on the edge of the bed. And the CNA that's being tested, the student will think to themselves, oh, the evaluator won't notice because I did everything right. It's not the steps. It's the patient. And if the patient is on the edge of the bed, it doesn't matter what a perfect job you did for the skill. Your patient is not safe. So at the end of every skill, I want you to take a second and step back and look at the person, not the skill, not the steps, the person. Do they look comfortable? Do they look safe? Is the bed in that low position, and is the environment nice and clean? Now, this gets overlooked a lot. And one of the reasons is, you know, in the skills videos that I create, the environment's always clean. There's not a whole lot of stuff on the table. This table's always empty, right? It's clean because I'm doing a skills video. This is not normal. But because that's what you guys see during training is this nice, clean environment all the time. At the end of the skill, nice, clean environment, nice, clean. Your brain tends to think that all environments are going to end nice and clean, and they don't. So be careful here. Be careful. Take a step back. Get your brain used to looking for problems to solve there. Make sure that the trash isn't overflowing, that the sheet isn't on the floor, that the patient is safely in the middle of the bed. This is at the end of every skill that we do. So it doesn't matter what skill we're doing. This is the end of every skill. Most skills are going to be done on a live testing student. The turning is going to be on a live person. So if you're the patient, yes. So if you're the patient for this and she's doing the skill on you, if she turns you super close to the edge of the bed, you can't say anything. You have to keep your mouth shut. Can you imagine being the one laying there, like super close to the edge of the bed, feeling like you might fall off and not say anything? Sometimes for me, keeping my mouth shut is probably a much harder thing to do. All right, so make sure that bed is in the low position. We want to ask if they're comfortable. They need to hear that word comfortable. Are you comfortable? And comfort isn't just physical, it's also emotional. So we're going to address preferences. You want the head of the bed left up or you want it down? Do you want a magazine before I go? Would you like your TV remote? Do you have your phone charger? Cup of water? Blanket? Do you need to go to the bathroom? I go through a whole list of stuff before I ever leave a patient's room. I got this whole checklist in my head because the more needs that I can take care of now, the less they'll be on the call light later. But for the test, we just ask about a magazine. You want to make sure they're covered. Every patient needs to be covered. Should I ever see knobby knees?
No.
No. So if you look at this patient at the end of the scale and you can see their knees, you should automatically think, oh, Miss Patty's not going to like that. Let me pull the sheet up. Okay. Good. So interestingly enough, I actually, through very strange circumstances, ended up talking to somebody who took my class back in 2011. 2011. Like some of you were barely even thought of. Okay. So, and it's funny because she says, you know, a lot of the things, and she's now going for her bachelor's of science in nursing. She's already an RN. She's been working as an RN for a long time. She's going for her bachelor's. And she says, you know, it's funny because when I walk into a room, I am always thinking about the little sayings that you said in class. So knobby knees, you will take that with you for the rest of your career. You will. I say things in a way that it's short, sweet, but they stick. All right, so once we've gotten all of those things done, we can open the curtain. You also have to give your patient the call light so they can call you if they need you. Now, all of these things, I don't care what order you do them in. Nobody cares what order you do them in. Give them the call light first. Go ahead. Open the curtain. Fine. Make sure that the bed is in the low position. I don't care how you do these things. Just do these things. The order here does not matter. In my mind, comfort curtain, call light, clean just kind of flows. Right? So are you comfortable? Open the curtain. Here's your call light. Environment's clean. Comfort curtain, call light, clean. But you can put it in any order you want to. I don't care how this gets done. But once you've done all those things, we have cootied up throughout this entire skill. So since you have cootied up, what do you want to do? Uncootie. Absolutely. Get to the sink. Get those cooties off of your hands. If you have to document, you would do it after you have washed your hands. But we have to end skill with clean hands. So if you document, what do you have to do? Wash your hands again. Now, if you return to that patient for any reason, let's say that you're done with the skill, you've washed your hands, you step back, you look at the patient and you realize, oh no, I didn't give them their call light. No problem. Go over and give them their call light, but you've just re-cootied up. So what do you need to do? Wash your hands again. So it is in your best interest to get all of that stuff done before you go to the sink. Good? Great job. All right. We learned how to take a pulse in class on Wednesday. Do you guys remember that? What's that? Oh, yeah. All right. When we're taking the pulse, we have to support the arm. So that elbow has to be supported on something, a chair, a table, the bed, something. Get that arm supported. Because if you hold that arm up, that muscle engagement is going to require more blood flow, which elevates the heart rate, which means we have a faster pulse than the patient should have because of what we have done. So that arm being supported is a big deal to get a baseline pulse reading. Simone, Miss Patty, are we supposed to ask the patient if they want their denture back in before we put them away after care? Well, Simone, I'm going to lead you to the, is that today? No. I'm going to lead you to the care plan on this one. So in our skills book, if you don't have the skills book, you probably need it. In our skills book on page 97, you will see the care plan for denture care. And the care plan for the test is going to tell us that the patient's denture will be stored in a denture cup at the side of the bed. So let me ask you that question. If our care plan says patient's denture is going to be stored in a denture cup after cleaning, can you answer that question for her? So should we ask them if they want their denture back in? Why? Care plan said. Do you guys see how easy that is?
Yes.
Okay, so care plan said, put the dentures in the denture cup on the bedside table. Patient asked, can I have my dentures in? As CNAs, we either follow the care plan or report it to the nurse. So let me ask you, how would you solve that problem knowing that information? That's right. That's right. Good. Okay. Pulses are always reported over 1 minute, but we're going to follow the care plan as to how long we have to actually count. Normals between 60 and 100. We're going to use our fingertips, not the flat area of our fingers. We never use our thumb, ever. Radial pulse is located at the very top of the thumb side of the wrist, way up here. For the test, we're going to say start when we start counting, stop when we stop counting, so the evaluators who are counting at the same time we do get the same number, hopefully. In Florida, chances are you'll count with 2 evaluators, but that's kind of up in the air right now. I don't know if you're going to have 1 or 2. When you guys go test, let me know how many evaluators you have, please. And then this is a documentation skill because the care plan told us to document. So if you don't document, you didn't follow the...
Yep.
As the nurse, I ask you to take a pulse and document it because I need that reading. If you don't document it and it's floating around in your head, does that help me?
No.
Does that help them?
No.
So you're not going to pass. Good. We learned how to dress somebody with a weak arm. So we're going to ask about their clothing preference. They get to choose their own clothing, and we're going to get that clothing before we undress them. We're going to lift from below with a flat palm. We're going to support as we lift. We're going to dress the strong arm first. I'm sorry, we're going to undress the strong arm first and dress the weak arm first. So USA first. We don't want to overextend or force movement. We'll adjust the clothing so it's nice and neat, fitting appropriately. And we'll put all the dirty items in the hamper. Don't leave them on your overbed table. Remember I said clean environment, right? That's what they're looking for, guys. They do not want to see stuff on the table at the end of the skill. So you need to be looking for that. We will put the call light in the stronger hand. We learned how to do range of motion as well. Now we're going to learn another range of, or actually 2 more range of motions throughout the program. But when we do range of motion, it's important to understand why we're doing it. Are we trying to make anything better? No. Who does that? Physical therapy. That's not us. We are trying to maintain what they've already got. So when we are doing range of motion exercises, we don't want to inflict pain. We're going to lift from below with a flat palm. We're going to provide 2 points of support near the joints. We're going to move slowly and smoothly all the way back to start. So let me give you an example of that. If we have flexion extension of the shoulder, that means we're going to go all the way up and all the way back down. Well, they want to see that full range of motion. That hand has to end where it started. If you go up and like this is not a full range of motion. It's got to go all the way back to start. No shortcuts here. Flexion extension is up and down, what I just showed you. Abduction, adduction is side to side. Rotation is around, but for the exam, there is no rotation that you'll have to demonstrate. Rotation is around. Yeah. Okay, so to recap, these are the 11 principles we're going to learn in class. We've learned skill rules, the opening, glove rules, linen rule, barrier rules, privacy blanket, linen rules, and the closing. Was that hard? You guys just recited them to me, so I know you know them. We have 4 more to go. We're going to go through part of this one, not much, but part of it. But we're going to go through these today. By the end of next week, you will know all of this. And again, we're going to keep reviewing at the beginning of each class. So by the time we get to the end of this program, you're going to be rolling your eyes at me. I got it. Do we have to do this again? Yes, we do. Because repetition is how I'm worming this into your brain. Okay? Trust the process. All right, let's take a look at page 116. We're going to get into our first skill today. Page 116 is hand and nail care. That's a tongue twister. This is the overview page. It kind of gives you a high-level overview of how the skill is going to be performed. Down here, you'll see all of the principles that are involved in this skill. They're all spelled out for you here. This is skill-specific information here. Down here is testing information. Somebody with your level of experience should be able to do this skill in 11 minutes or less. We're going to read the care plan in just a minute to figure out what we have to do within that 11 minutes. But they're giving us 11 minutes. This is going to be done on another live testing student like you. That person will be sitting in a chair. And documentation is not required for this particular skill. If you go to page 117, this is our step-by-step instructions along with the supplies that we need for this particular skill. I'm going to sit for this for a few minutes. Care plan is not going to tell you what supplies you need for any skill. It's not going to tell you to go get a barrier, a basin, soap, lotion, 2 washcloths, a towel, an emery board, and an orange stick. You have to know that. The only way around this is through it. Means you've got to memorize it. Flashcards will be your friend. Make flashcards. Again, we have them. Right now, I am waiting for them to be finished. But we will have them later this week. But you can make your own. You don't have to wait on us. You can make your own. Okay? But you do have to learn your supplies. Now, question I get asked a lot is, well, what happens if I get the wrong number of supplies? What if I just get too many washcloths for this skill? What if I can't remember and I just grab a whole stack of washcloths? Well, that's supplies. You aren't graded on supplies. There's no checkpoint that says got the right amount of supplies. You're not graded on supplies at all. You are graded on what you do with supplies. So if you don't have enough washcloths, if you only got 1 washcloth, and you have to wash and rinse, that might be a problem for us. Because you can't rinse with a soapy washcloth. Right? So you're graded on what you do with the supplies, not getting the supplies. Does that make sense? You guys follow that? Okay. If you try to get too many, that evaluator may tell you you don't need that many supplies for this skill. Now, the reason for that is, remember, they're testing 8 people a day. This is all they have for testing. That's it. Whatever's on this shelf is what they have for testing. Which means if you grab 10 extra washcloths that you don't need, and you grab 10 extra washcloths that you don't need, and you grab 6 extra washcloths that you don't need, by the time we get over here to you, there aren't any washcloths left, and you have a washing skill. What are you going to do? Well, that's not fair, is it? So the evaluators, if you try to take an insane amount of supplies, they're going to stop you because they want to make sure that there's enough supplies for everybody to test on that day. They're not going to run out to Target to get some more washcloths. Good?
Yes.
Make sense? Now, if you just take an extra 1 or 2, they're not going to say anything. However, they are going to grade you on what you do with those unused supplies. What do we know about what we have to do with unused supplies? That's right. You have to discard them. Don't leave them in the room. That's why that's a principle. Good. You're starting to see that you really have all the knowledge you need. All right. So let's look at the care plan at the top of this page. Oh, that's what I was just talking about, supplies. No. All right, here's our care plan. This is the same care plan that's at the top of the page. It says provide hand and nail care to one hand. The patient is sitting in a chair at the bedside and can move as directed. So if you look at all of the principles involved, you can see that there's a couple there that we don't know yet. Jake, can I put you in charge of advancing slides for me for a minute while I sit? Thank you. Go ahead. I know you weren't set up. I'm sorry. Okay. So if you look at all of those principles on the side, you can see that we know skill rules. We know opening, glove rules, barrier rules, linen rules, and the closing. So we can put those aside. We know those. It's just rinse and repeat. But there's two on this list we don't know yet, and that's what we're going to have to learn this morning. So the first one we have to learn is washing rules. This is going to be detailed on page 112. And you can see that washing rules are going to be used in 5 skills. So we're going to learn it once, but use it in 5 specific skills. Anything you wash is always going to be washed the same way. Doesn't matter what body part it is, it's going to be washed the same way. Page 113 has the notes for the lecture that I'm about to give you. All right, so I want you to think about the way you wash. Now, most of us shower. And when you get into the shower, you get wet. Then you get some soap on a loofah or a washcloth or whatever it is that you happen to use, and you suds up. Do you get out of the shower then? What do? Rinse off. You wouldn't dream of soaping up and getting out of the shower. It just wouldn't make any sense to you. The job is not done. It would be kind of weird. You don't put shampoo in your hair and then get out of the shower. Rinsing is a part of what we do, but that's a problem because it's a part of what we do and then we don't think about it. So I've got to make you aware of all of these steps. You already know them, but I've got to bring this to the forefront of your thought process. Because when you are bathing somebody else, it is really easy to forget to rinse. Scary easy to forget to rinse. Now, I had a student from my January class who failed the skills exam, and she sent me her printouts, her feedback. She had pericare, and I told you this last week, and I was looking at the feedback. She did not rinse. Peri area is the personal skin area below the belt. Can you imagine having soap dried in your peri area? What do you think that would feel like? Uncomfortable, itchy, which means the patient's probably going to have to scratch it, which means we risk putting skin openings in a warm, dark, moist area. Is that good for anybody?
No.
So she did not pass. Do you think that that was unfair that she didn't pass? What do you guys think? I feel bad for her. I do, because when you're testing, it's easy to lose track of steps. But I don't feel bad for her because I know that the patient would have suffered. And who's the test about? The patient. That's right. It's not about what steps did you miss. It's what impact did those steps have on the patient. You guys starting to make that switch in your mind? Okay. Okay, so whatever we wash, we rinse, right? So if we have to have rinse water in the shower, we just use the water that's coming out of the faucet. That makes it easy. It's right there. It's clean water. But when we're bathing somebody in a bed or at a table, we don't have running water. We have to have rinsing water. So in order to make sure that we have rinsing water, we don't put soap into the basin. We keep that water clean. Go ahead. Go ahead, Jake. Thank you. So since we have to rinse the soap off the skin, we don't add soap to our basin water. We want to keep that water clean for rinsing. So that means that we're going to get our washcloth wet. We're going to wring it out really, really well. And we're going to put soap on the washcloth to wash the patient. And then we'll set that soapy washcloth aside. Don't put it back in the basin. We'll set it aside, and that keeps our water clean for rinsing. Good? So a little bit different way of thinking about it. All right. When we get water, well, let me time out here for just a second. I know a lot of you said that you've been a patient in a hospital. When you left the hospital, about a week later, what did you get in the mail? A bill. That's right. Pay us. And this isn't $5, is it?
No.
It's big money, right? Everything that you use on that patient in that hospital was billed to that patient. Everything. Now, unfortunately, the hospitals don't go shopping at the Dollar Tree. That basin averages between $35 and $45 for the basin. I can go to the Dollar Tree and get one that looks just like that, but that's not where they're shopping. So a lot of CNAs will go get a second basin so that they can have one soapy basin and one clean water basin for rinsing. You've just charged that patient for something that they don't need. Is that fair?
No.
So this is how I think about it, because I'm real big on analogies, right? So this is how I think about this. Have you ever gone out to dinner? When you decide, when you make that decision to go out to dinner, you generally pick a place that you can afford that's in your budget. Because you know you have to pay for the meal, right? So imagine you walk into a restaurant and there's no menu. They decide what they're going to serve you. And you have absolutely no idea how much they're going to charge you for that. And at the end of the meal, they're going to give you a bill and you have to pay it or they're going to take you to court. That is our modern healthcare system. We do not get to choose what is used on us. We do not get to make decisions about how we're charged. And we have no idea what the cost of those items are going to be. Yet we get a bill in the mail and we have to pay it or they will take us to court. Now, as CNAs, we influence this because we are the ones that work with the patient the most. We are the ones that go into that supply closet and get stuff for the patient and scan it out to charge it to their bill. The majority of the things that are on that healthcare bill, itemized, are going to be things that the CNA put on there. So that means that we have to be aware of this. We have to know that everything we scan is going to be charged to that patient. So we've got to be smart about how much we add to their total bill. Because even with insurance, you are still responsible for a portion of that. Good? Makes sense? Anybody have a baby recently? Anybody have a baby recently? Do you know how much it costs you to have the baby?
I don't remember a lot.
It's like over 30,000 now, isn't it? Yeah. Yeah. That's insane. That's a lot of money. It's a lot of money when you don't have insurance. Yeah. Yeah. We got to be smart about this, right? So don't just go grabbing supplies that they don't necessarily need. And we don't need it if we make sure that we don't put soap or soapy washcloths into the basin. All right, when we go get that water, so we've done our opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands, get our barrier, get our supplies, and now we're ready to go get the water in the basin. So I pick that basin up and I carry it over to the sink and I'm going to put water in it. Now, so far I've washed my hands. Remember, I washed my hands after I did my opening before I got my supplies, and all I've touched are clean supplies. So should I touch that faucet to turn it on with my bare hands?
No.
Why? Hands are clean, faucet is dirty. That's right. So what could I use between my clean hands and the faucet? A paper towel. And that would keep my hands clean. So I'm going to use a paper towel to turn the water on. Now, I didn't need that paper towel when I turned the water on to wash my hands because my hands were dirty then. But now my hands are clean and I want to keep them clean. So I'll use a paper towel to turn the faucet on. Once I have that water on, I'm going to use the inside of my wrist, and it should feel warm, not hot, not cold, just warm. And then when I'm comfortable with the temperature, I'm going to fill the basin about half full, whatever my wrist can carry at this point, really. Doesn't have to be full. And I'm going to take it over to the patient. But here's the problem. That patient may not have the same perception of temperature than I do. They may not. Or the patient has a totally different preference of temperature than I do. I'm the type of person that likes my water, my showers, hot. I want it to take skin off. I like it hot. If steam isn't billowing out, it is not hot enough. My husband will walk into the bathroom and go, oh my gosh, what is going on in here? Because he likes cool shower. He works outside in the sun. It is hot out there. It was like 90 degrees already. It is hot. He does not want hot in the shower. He wants cool, right? We have two totally different preferences. You guys all have a preference of how water feels comfortable to you. Make sense? Your patient will have a preference. It's not up to us to force them into our way of thinking. I'm going to give you an example of this. There have been very, very few times in my nursing career that I have gotten really angry with the CNA that I've worked with. There are very few. One of them was when a CNA told me, well, she started it. That set me off. But this scenario I'm going to tell you is the one that really sticks out in my mind. I was in a nursing home. This is early on in my career. I was in a nursing home sitting at the nurse's station, which was like, there was a hallway down here and a hallway down here, and right in the middle is the nurse's station. And I'm documenting, it was something pretty significant because it took a lot of brain power. I'm sitting there documenting. 30 years ago, I can't tell you what it was. But I'm sitting there and I'm hearing screaming. I'm talking ear-piercing screaming from down the hallway. So I drop my pen. I go running down the hallway thinking, this is, whatever it is really bad because, maybe a masked intruder. I mean, there's got to be something bad. And as I go by the shower room, I could tell, oh, wait, it's coming from here. So now I'm thinking, oh my gosh, somebody slipped and fell. So I wrench open the door and steam comes billowing out at me. And to the point, it was so steamy that my glasses immediately fogged up. I couldn't see a thing. So I'm now kind of, doing one of these things, walking in the room, and the screaming is still continuing. And now I'm hearing the CNA saying, stop it, just stop it. I mean, like mean. So I whip my glasses off because I got to see what's going on. And in the shower chair is this naked older woman who is hitting, flailing, kicking, doing everything she can to protect herself. I'm like, oh my gosh, what's going on here? And the CNA is standing in front of the patient, but kind of got her hands extended, trying to push the shower chair under the water. So I walked over, immediately turned the water off. What is going on? Grabbed a bath blanket, threw it over the patient. What is happening in here? And the CNA said, I'm just trying to give her a shower and she's being non-compliant. Now, we use that term in healthcare a lot. I do not ever want to hear that. If a patient says no, they're not being non-compliant, no means no. You have the right to say no. So does your patient. That does not make them non-compliant. And I said, of course she doesn't want to be under the shower. It is steaming hot. CNA says, oh no, I checked it. It's fine. Okay, the steam would say otherwise. This patient was red. Red. I told the CNA, go outside. I'll be out to speak to you shortly. Outside, not in my unit, outside. I got the patient dried off, took her back to her room, got her dressed, got her into bed, apologized up one side and down the other, offered to get her favorite ice cream, tried to smooth this over. And what I was trying to do is buy myself time, because if I had gone out to talk to that CNA at that moment, I probably would have killed her. This is somebody's mother. We don't treat people like this. If the patient says no, there's a reason they're saying no. And in this case, they were saying no because the water was too hot. Now, for the next several months, this patient did not want to be bathed. Do you know why? Absolutely. So what this one CNA did was alter this patient's perception of healthcare for everybody moving forward. Everybody. This was horrible. And I still remember this CNA. And this is probably about 25 years ago now. Hey, this is probably about 25 years ago now. So remember that what we do matters. The state understands this. And this is an actual checkpoint, guys, that the patient has to check the water. It's not enough that I think it's comfortable. The patient also has to agree that it's comfortable. It's their body we're washing. This is a checkpoint. But let me explain to you why this might be a little more important than you guys understand, than just preference, right? So we have to understand that the skin is going to change as we age. I'm actually seeing this on me. I'm seeing this on me. But when we're young, our layers of skin are thick. We have, hi, you're good. We have a thick layer of skin. We have a thick layer of muscle, and we have in between a thick layer of fat. And what this does is it helps cushion everything. It helps protect the blood vessels. When you look at you guys' arms, you don't really see the veins underneath the skin very well, right? You look normal. This does not last. As we get into middle age, each one of those layers is going to shrink. But as we get into older adulthood, the layer that goes away is that fat layer. Go ahead. Have you ever seen an older person's arms?
Yeah.
Do you see that?
Yeah.
Can you see the difference?
Yes.
You can see that that fat layer is gone. This is visible. Well, what does that fat layer do? Why should we care? It does. It keeps you warm and protects you. But let's get into the specifics of that. So you've got this fat layer and it actually acts as a wetsuit. And the whole purpose of this is our body temperature has to remain at 98.6 degrees. And it's kind of a range, 97.6, 99.6. But we're going to kind of cut to the middle and say 98.6 degrees is where we should be. Good? Okay. Well, your body doesn't stay at that temperature naturally. It doesn't. Your body has to work to get to 98.6 degrees. What do you think room temperature is on average? 74, 75. I like easy numbers. Let's go with 75. Okay. Room temperature about 75 degrees. Everybody good with that?
Yes.
How hot did I say it was outside a few minutes ago? 90 degrees. Okay. So if you walk outside, how are you going to describe that temperature? Hot, especially compared to 75 degrees, right? It's a big difference between 75 and 90. So in here, comfortable, out there, hot, right? What did I tell you we are? 98.6. So we're hotter than outside. You don't think about it, but you are. 98 degrees. It's not arbitrary. Problem is that room temperature always wins. Always. If I'm baking a pie in the oven at 325, that pie starts to bubble, right? It's 325 degrees. I take it out of the oven. It's 325 degrees. I put it on top of the stove. It's 325 degrees, but I leave it there for a few hours. When I come back a few hours later, is it 325 degrees? No, it has cooled down to room temperature. Room temperature always wins. Now, pie goes well with ice cream. So I reach in the freezer and grab a carton of ice cream out, and that ice cream is 0 degrees. It was in my freezer. I take it out and put it on the counter, and it's 0 degrees, but I leave that ice cream on the counter for a couple hours. When I come back, is it still 0 degrees? What is it now? Room temperature, because room temperature always wins. Now, here's the problem. We have to be at 98 degrees. Room temperature is 75, and room temperature always wins. So that means that unless we have something active to make us 98.6 degrees, we're going to cool down to 74 because room temperature always wins. So this is where we get into something a little bit technical. Your body has a mechanism of creating heat. It's called burning calories. This is why you eat. You eat for nutrition as well, but you really eat to keep yourself at 98.6 degrees, because if you fall below 93 degrees, you die. Below 95 is hypothermia. Below 93, dead. So this is serious. We have to be able to generate heat to keep our core temperature high enough that we don't die. And that's what your digestive system does. It burns food to create heat. Now, when we're young, we got this wetsuit thing. We got this layer of fat all over our body that's going to keep that warmth inside. So we don't have to work so hard to stay at 98.6 degrees. Your body burns a few calories, creates enough heat, and then that wetsuit keeps it all inside. It's a great system. But as we age and that layer of fat goes away, what do you think is going to happen to the body heat that's generated? It's going to dissipate. It's going to go away, which means the patient is going to feel much colder, and their body temperature is probably going to be a little lower. Have you ever walked into grandma's house and you're like, oh, grandma, it is hot in here? It's like 86 degrees. And she's like, oh, I'm good. You're like, no, it's hot. Let's turn on the AC. Or little old lady sitting there shivering in a sweater and you got a tank top on. And you're like, you are nuts. It's because they have to use external means of providing or maintaining heat, preventing heat loss. If you've ever heard an older person say, because they all moved from up north to Florida, and they'll tell you, I can't tolerate the cold anymore. I just can't be up there. It's too cold. I can't tolerate the cold anymore. They're right. That's real. That is not in their head. It's actually in their body. Right? So if we know this, if we know that that fat layer is there to keep inside temperatures in and outside temperatures out, and we know this loss of fat is going to impact our patients, that privacy blanket becomes way more important than we think it is. Good? Make sense? It also means, go ahead. It also means that because that layer of fat isn't there, that protective layer, bless you, then your patient may feel the temperature much differently than we do. Because we have that layer of fat between us and the temperature of the water that they don't have. So if I get water and it's warm, but I take it to my patient and they go, oh no, it's too hot, I'm going to listen to them. And I'm going to go cool it down a little bit. Having your patient check the water temperature is vital. That is what we call a critical concept on the state exam. If you do this skill and you do not ask the patient to check the water temperature, it could fail you. That one step. Good? Do you guys understand why? No matter what your brain tells you about that water temperature, listen to your patients. Go ahead. So I'm going to time out here for just a second. We'll take a break in a moment, but I'm going to time out for just a second because I want to talk to you about a condition called dysautonomia. And this is, it's way more common than it used to be. I think it's actually, I don't think it's more common. I think we're recognizing it more often. I think that physicians are actually looking for this now. But dysautonomia is often found with certain genetic diseases or autoimmune diseases, and it results in a patient's inability to regulate their temperature properly. And if we have a younger person, right, we tend to think of this, what we're talking about, as an old person problem because the layer of fat dissipated. It got resorbed with age. But a lot of our younger people that have autoimmune disorders or genetic problems will also suffer from dysautonomia. And this can be a very big deal for them. Because if you use really hot water on somebody with dysautonomia, they may not be able to recognize the fact that it's too hot, and it may affect their internal temperature just from that radiant heat. So we have to be somewhat aware of when we're bathing our patient, if their skin is turning red, that should be a clue to us that, wait a minute, that's an observation, right? Or if their skin is blue and they're shivering, that should be a clue to us. They may not recognize that they're cold, but our signs are showing us that they're cold. Is that something we should be reporting to the nurse?
Yes.
Absolutely. Good. Does that make sense? Okay. All right. So we're going to ask our patient to check the water every time. Doesn't matter what we're doing, why we're doing it, when we're doing it, patient checks water every time. But we're also going to pay attention. Sometimes these things can take us a little bit longer, right? Sometimes these things can take us some time. I don't think I read to you the whole care plan. All right, so this skill, this is hand and nail care. It's telling us, and I want to read the care plan so I can explain this. It's telling us to provide hand and nail care to one hand. Guys, this is a mini-mani. we're going to wash one hand, rinse one hand, dry one hand, clean under the nails, file the rough edges, and put some lotion on. That's it. You probably could do this in 2 minutes. If you remember when we went over the overview, I told you you had 11 minutes to do this skill, right? It's a long time. If we're only using lukewarm water and we're taking all 11 minutes, that water is going to get cold. So we have to kind of be aware as we're doing this. If we put our hands in the water and it's cold, even through gloves, you can feel that it's cold. You need to change that water. Don't rely on your patient to say, oh, it's too cold. Just change the water. Also, if you get it soapy, change the water because soapy water isn't going to rinse anything. So this is kind of up to us to watch for. Change the water if it gets cold or soapy. Go ahead.
So if you change the water, does it mean do we have to go through the whole thing again as far as taking gloves off?
Depends on if you're wearing gloves.
Or
Right.
you can just put the towel.
Paper towel.
and then
Paper
remove it
towel
and-
solves all. That's what I was going to say. Paper towel solves all your problems. Yep. Okay. So now that we know everything we need to know to wash, right? So we know that we're not going to add soap to the basin. We know that we're going to use a paper towel to turn the faucet on. We know we're going to use warm water. We know the patient's going to check the water. Now that we've got all of that done, we're going to get to the actual washing part. Whatever we wash, we rinse. Whatever we rinse, we dry. Pretty easy. But I want you to get used to saying that to yourself. Whatever I wash, I rinse. Whatever I rinse, I dry. It's second nature when we do it on ourselves. But when you turn around and do this on somebody else, you will forget one of these steps. You will. So if you start to get used to saying, as you're doing the steps, whatever I wash, I rinse. That'll take you to rinsing. Whatever I rinse, I dry. That'll take you to drying. If you start getting used to saying that in your head when you're doing these skills, you won't accidentally leave soap on the patient's skin, which could dry the skin, cause skin openings, cause itching, and leave your patient just absolutely miserable. Okay? So start to get used to saying that. Whatever I wash, I rinse. Whatever I rinse, I dry. Go ahead. Change the water if it gets cold or soapy. We talked about that. Try not to get your surface wet. For this skill, your patient is sitting in a chair at an overbed table. We're going to put the barrier on the table, but we want that barrier absorbent side up so that if we spill water, it gets absorbed. It doesn't drip onto the floor. Any water on any surface has to be addressed. So during the test, if water drips onto the floor, that evaluator saw it. I guarantee you that evaluator saw it. As a nurse, I am trained. I assess as easy as I breathe. I pick up little details that you guys aren't even aware of because I've been trained to do it my whole adult life. That evaluator saw that that water dripped on the floor. If you don't address that, it could count against you. Paper towel, clean it up. Yep, after you've cleaned up all of your supplies, before you wash your hands, wipe up that floor. But if you have your barrier on the table, absorbent side up, it should catch all of that water. Okay. Now, at the end of the skill, just before you wash your hands, but make sure you address it because that water on the floor becomes what kind of a hazard? Slipping hazard. And that's, again, they're not grading you on you. Who are they grading you on? The patient. Good? Okay, and then we're going to put some lotion on. Anytime we put lotion on, we warm it up in our hand. Don't squirt cold lotion on your patients. Don't do that. Warm it up in your hands, wipe it off, and then we'll wipe off the excess. Your skin can only absorb so much lotion. Whatever's left stays on the surface of the skin. If that patient goes to pick up a cup of hot coffee and you just put lotion all over their hands, what's going to happen? Again, this is all about the patient. So wipe off that lotion. Good? With a towel. Yep. So we have a towel right there that we use to dry the hands. Just use that same towel. Okay.
On the soapy, go back to the soapy washcloth. And, we put it into their,
We wet the
thing
washcloth,
in
right?
water. Then we put the soap on the washcloth.
Right.
So now are we soaping up whatever whole part of the body or just some of it? And then are we setting the washcloth down on the barrier
Okay.
and then rinsing and then go into the next body part or whatever?
Yep. So let's look at this particular care plan. Okay. So let's look at page 117. And I'm doing this very specifically, very strategically. I could give you the answer, but that's not going to help you. I need you to know where to find the answers moving forward. So can you read this care plan to me?
Provide hand and nail care to one hand. The patient is sitting in a chair at the bedside and can move as directed.
Okay, so how many hands are we washing?
One hand,
Are we washing the arm?
No.
What are we washing?
the hand. So that's all I'm doing. Okay.
Right. Good.
Mhm.
Now, I want you to keep your finger there. Keep your finger there, but go to page 127. Can you read this care plan? I know it's long.
Give the resident a partial bed bath and a back rub. Wash the resident's face, neck, chest, abdomen, back, and one arm and hand with soap and water.
Okay, so stop there. So that care plan tells you exactly what to wash,
Mhm.
right? So to answer your question, it depends on what the care plan says.
Okay.
But in general, I'm going to give you some very general guidelines, and we're going to cover this in detail when we get to partial bed bath. But in general, any washcloth that washes body openings, you guys remember hearing about holes, right? Body openings. That washcloth is not going to be used anywhere else on the body. So I'm going to use a washcloth to wash the face. I'm going to wash the eyes. I'm going to wash the nose and the mouth. We're going to use a very special technique we'll learn when we get there. Okay. But I'm going to wash the face. I'm not using that washcloth anywhere else. That's going to go on my barrier, not back in the basin, on my barrier, not on the floor, on the barrier. Then I'm going to get another washcloth to wash the neck, the abdomen, one arm and hand. All that skin is intact. Okay. Does that make sense?
Yes.
And I'm going to put that washcloth on the barrier, not back in the basin because it has soap on it. So anything with body fluids or, any holes, right? Or anything that has soap in it or on it cannot go back into the basin. Does that help you?
Mhm.
Okay. So I could have given you the answer, but I need to lead you there
And I appreciate that. Yeah.
so that in the future you can reason that out. You can connect those dots.
Do you have to we change the towels every cycle you do as you do it in the patients?
So let's concentrate on this skill that we're learning right now. And we're going to talk about multi-step, wash, a skill that requires multiple washcloths a little later in the program.
Okay.
So let's focus on kindergarten before we try to do 8th grade.
Okay.
Okay. Does that make sense?
Yes.
Okay. So go ahead, Jake, if you would. All right. So our washing rules that we just went over, let's recap it one more time, and then we're going to go on break. Basins are no soap zones. Use paper towel to turn the faucet on. We're going to use warm water only, not hot, not cold. We're going to allow the patient to check the water temperature. Don't worry about the next one. We'll work on that later. We're going to wash, rinse, and dry. Change the water if it gets cold or soapy. Don't get your surface wet. And warm lotion up before you put it on. Wipe off the excess. Any questions with this? So we're going to take these rules and apply it to this care plan. Just this one. That's the only one I want to focus on right now, is just this care plan on page 117. We have other care plans coming up that are going to be much more complex, but we'll start simple. Good? Okay. Now, unfortunately, because we use this basin to clean, we have to clean the basin before we can put it back. And that's going to be the next thing that we learn is basin cleaning. So all basins are cleaned the same way. Doesn't matter what they are. Could be a bath basin. It could be an emesis basin. It could be a bedpan. It could be a graduate container. It doesn't matter what it is. If it holds liquid, we're going to clean it the same way. Good? We're going to use one process. And it doesn't matter whether we are going to spray it with a disinfectant or simply rinse it. We're going to do it using the same process. And that's what we're going to get into next. But let's go ahead and take our break first. And then we'll get into basin cleaning. And then I'm going to show you how to do hand and nail care. Jake, I'll make a note, 86. Okay, thank you. And if you can put me
86.
back on 86. All right. We'll go ahead and get started and they can join in when they come back. Any questions on washing rules? Does that make sense? Good. Okay. So go ahead and advance me, Jake, if you would, please. The next thing that we're going to talk about is, now that we've gotten washing rules over, is basin cleaning, which is going to be located on page 90. Now, all basins are going to be cleaned the same way. And we're going to see this in 1, 2, 3, 4, 5, 6, 7, 8, 9 skills. So we do a lot of basin cleaning.
You just don't throw them away.
No, because remember that everything is going to be charged to that patient. So if we've used something, there's no need to throw it away. We can simply clean it. Now, sometimes cleaning will just be rinsing, drying, and storing. And other times cleaning will involve disinfection. Okay. It depends on the situation. It depends on the patient. It depends on a lot of variables. So let me give you an example. Let's say that I'm doing hand and nail care on you. Now, this basin is only used by you. I'm not passing it around the facility. We don't use it on other patients. That patient is checked out of central supply, billed to you, and it is your basin. It will stay in your room and your drawer. It's yours, not used by anybody else. So if I do hand and nail care on you, all I have to do is rinse that basin, dry it out, and put it back. You're the only one that will ever use that basin again. But let's say that I'm working with a patient that has cancer and is undergoing chemotherapy. Now, when we do chemotherapy, what we're trying to do is kill their immune system. That is the whole purpose of chemotherapy. We're trying to wipe out their immune system to reset it. Well, if I know somebody doesn't have a good immune system, and I know that we're in a setting that has a lot of pathogens, then that particular patient, I would probably want their basin disinfected before I put it back. Because remember, in this drawer where the basin's going to go is warm, it's dark, and if I don't dry that basin off completely, I've added moist, which means that pathogens might have an opportunity there. Not necessarily will, but might. But that's a risk I really don't want to take with this patient because they don't have much of an immune system. So if I'm writing a care plan for a patient that's on chemotherapy, their care plan is going to say all basins must be disinfected. If I'm working with you, I don't need that. Just rinse it, dry it, just clean it, right? So in my house, I might clean it with soap. I might just rinse it out. Whatever I need at that time. Does that kind of make sense?
Yes.
Okay. So we have different cleaning for different purposes. Now, for the test specifically, everything is simply rinsed, dried, and put back where we got it. That's it. We don't have to disinfect anything. Now, we're going to see basin cleaning a lot through this program. About half of our skills have basin cleaning. We're going to see it over and over. If you don't get it right this minute, it's okay. You're going to see it again and again and again and again. But right now, we're just going to kind of go over the basics. And as we go through the program, it'll become a little bit more routine to you. Does that make sense? All right. So Jake, if you can advance me, please. Page 91 is going to have the notes on this. So you can follow along on page 91. But when it comes to basin cleaning, if we're going to clean a basin, that means it had something in it. Could be water, could be saliva from mouth care, could be urine from emptying the drainage bag. It could be body fluids from the bedpan, but it's got something in it. We're not cleaning empty basins. So the first step is we got to get the basin empty. So that means we've got to dump whatever is in the basin. Now, this gets students messed up all over the place, and nobody cares. You guys make a much bigger deal out of this than it actually is. Put the stuff where it would normally go. How many of you guys brush your teeth over the toilet? That's kind of weird. So we probably don't need to dump mouth care fluids in the toilet. Where would you put those?
In the sink.
Yeah, because that's where it normally goes. Now, if you're throwing up, where do you normally head? The toilet, right? So if we're dumping emesis, where would we dump it?
The toilet.
In the toilet. You starting to get that, right? When you shower, where do you shower?
In the bathtub.
In the tub, in the bathtub, right? In a shower area, right? Well, unfortunately, we don't always have one of those. So where would the next best place that has running water be?
Sink.
The sink. So if you're working with bathing water and don't have a shower to throw it in or a tub to dump it in, you can dump it into the sink. Perfectly okay. Now, a lot of people will say anything below the waist would go in the toilet. Nobody cares. There is no rule. Nobody cares. But the way that I'm going to teach you to clean that water, it's important that you understand this. That water in that basin, we don't put dirty rags back in the water. So that water is just water. If you want to dump it in the toilet, go right ahead. But if I'm doing foot care, it doesn't matter. Okay, does that make sense? Good. So dump it where it normally goes. The biggest thing that they're testing you on here, there's no rule that says peri-care water has to go in a toilet or foot care water has to go in a toilet or anything below the waist has to go in the toilet. There's nothing that says that. The only requirement is that elimination fluids do not go in the sink. And that just makes sense to me because urine in the sink is pretty high on my gross meter, right? That's it. That's all that they care about. That's it. But we as students tend to make a much bigger deal out of this than it actually is. Just dump it where it normally goes. Good? Okay. Once we've dumped whatever was in the basin, once we've dumped it, now we have to rinse it. So at the sink, rinse it. Again, this isn't a big deal. Just rinse it. Now, we have dirty hands or dirty gloves, depending on the skill, and the faucet is dirty, so we don't need a barrier. Just turn that faucet on and rinse. If you can't remember whether you need a barrier or not, just use one. There's no penalty in using a barrier too often. Okay, good? Okay, so we're going to rinse it. But the rinse water needs to go wherever you dumped the body fluids or the basin contents. So if you are working with a basin that held elimination fluids, like a bedpan, and you rinse the bedpan, don't dump that rinse water in the sink. We would rinse it and dump the rinse water in the toilet. So good? So dump the fluid wherever it normally goes and then dump the rinse water wherever that fluid went. Any questions so far? Okay. So we're going to empty our basin. Jake. We're going to rinse the basin, dump that wherever we dump the basin fluids, and then we're going to set that basin down in the sink. Now, this is the step that is really confusing to students. And I'm, like I said, if you don't get it this specific time, it's okay, because we're going to be doing this 9 times. You'll see this again. But we're going to dump that rinse water and then set our basin down. And here's why. If I have to disinfect that basin, I only want to teach you one way of doing this, just one. Right? I don't want to I don't want to teach you something they say, well, if it goes this way, we do this, and if this, we do that. No, we're going to do one process. So we're going to set that basin down in the sink. And that's because if I have to disinfect it, I cannot be holding it while I disinfect it. My hands are not clean. So I'm going to put it in the sink and hands off. And then, go ahead, Jake. Once I have it set down in that sink, I can spray it with my disinfectant, whatever that process is at your facility. Follow your facility's process. I'm going to spray the basin. Now, my hands are still not clean. So now that my basin has been disinfected, I have to pick it up to be able to dry it. So once I have sprayed that basin, I cannot pick it up with that hand. So what could I use between my hand and the basin? A paper towel. Then I'm going to get a paper towel to dry the inside. Throw that away. A paper towel to dry the outside and throw that away. And then one more to gather my supplies and open the drawer. Remember, I still have dirty hands. I don't want to touch the outside of this with dirty hands. Good? So we dump it, we rinse it, we dump it, we set it down and spray it if necessary. We use a paper towel to pick it up, paper towel to dry the inside, throw it away, and a paper towel to dry the outside. Now, the reason we use 2 separate paper towels there is because the inside was sprayed. The outside was not. Okay? The inside is what holds the body fluids or the water or whatever. Good? And then we'll pick up our supplies with a paper towel and open the drawer with a paper towel to restore that basin. So the process is actually pretty simple. Dump it, rinse it, set it down, spray it. Paper towel to pick it up, paper towel to dry the inside, paper towel to dry the outside, and one more for the drawer. And you're going to hear me say it like that 9 times. So you'll get it. But I don't want you to get all tripped up on this one, okay? They don't grade you harshly on basin cleaning. As long as that basin is dry when it goes back in the drawer, that's all they care about. But I need you to have a process in place that you can use either if we're just rinsing, drying, and storing, or if we have to add disinfection in. Good? Any questions? For the test, we're not disinfecting anything. We're just rinsing, drying it, and storing it. We used to. There used to be a can of Lysol there for you to spray the inside of the basins for every skill that required a basin. This is one of those areas that I disagree with the test. Vehemently disagree with the test. They don't ask me. They don't listen to me. So I can just sit over here and rant and rave all I want. They don't care. But my problem is, and I understand why they got rid of the disinfection, and that's because we don't know which ones of you have asthma. And spraying a disinfectant could trigger an asthma reaction, and, you know, there can be a problem there. I don't like this because during the test, you are testing and you'll also be a patient. You are testing and you'll also be a patient. You are testing and you'll also be, and you are testing and you'll also be, and a patient. Do you guys see? Nobody is disinfecting these basins. That's a problem. So I don't like this rule. I understand why they got rid of disinfecting. I do. I get it. But I don't like this rule because you are a patient during these skills. And I think it takes the focus off of the patient. Good. At the end of the test, after you are a patient, what do you think you should do? Yeah. Good. Makes sense. Okay. All right. Any questions on basin cleaning? So that one's easy. We're going to see this a lot. Doesn't matter what kind of a basin we're cleaning, whether it's a bath basin, emesis basin, bedpan, or graduate container. Does not matter. We clean them all exactly the same way. Okay. Good. All right. So now that we finally know all of the principles we need to know, we can get to the first skill. So go ahead, Jake. Bless you. So if you look at this, remember, these are the checkpoints that we need for this particular skill. Okay, these are the actual checkpoints you're being graded on. Can everybody see that on the screen? All right. So green is our opening. Look how many things were checked off by green. You guys see that? Yellow is glove rules. That's been checked off. Blue is barrier, or I'm sorry, the aqua is barrier. That's been checked off. Gray is linen rules right here. That's been checked off. Blue is washing rules. Those have been checked off. Pink is basin cleaning. That's been checked off. So all that's left are the skill specific steps. And that makes up less than half of these steps. Less than half of the steps are based on this specific skill. The rest of it is all stuff on the back wall that we already know. Best nursing practices applies to everything. So when you think of it that way, there's really not much to learn for this skill if you know all the principles already. Now, the reason that I teach this, I didn't always teach this course this way. I actually, I would show you hand and nail care, and then I would show you foot care, and I wouldn't draw any parallels between them. I would just teach. The reason I started doing this is because remember that your education does not end with the test. It begins at the test. Because when you go to work, wherever you go to work, you're going to have other skills that you're going to have to learn for that work setting. Remember we talked about delegation? You guys remember that? So if you have other skills that you're going to have to learn and you don't have me spoon feeding it to you, which is what I'm doing here, you have an education coordinator that's just going to kind of throw you steps. You need to be able to connect those steps to something familiar. All washing is done the same way. Doesn't matter what body part you're washing. It's all done the same way. All linens are handled exactly the same way. Nobody should ever have to tell you when to use a privacy blanket. Nobody should ever have to tell you how to clean a basin. You already know that. So they can just focus on the steps that you need to learn for that skill. And you'll automatically go into every new skill knowing some things you need to know. So it makes it not quite as scary. Good? Does that make sense? This system works. It works well. But it doesn't just work for the class or the test. It works beyond. Go ahead. All right, so let's learn the steps we need to learn for hand and nail care. First, we're going to follow that care plan. Then we're going to do our opening. We'll evaluate if we need gloves. Let's time out here for a second. Let's talk about gloves. Remember I said that one of you guys is going to be the patient for this. So if you are the patient, this is not personal skin. Your hands are not personal skin. Your hands should not have any body fluids. So the only possible here is a skin opening. So for me, if I have, like I've got puppies at home, if I have a big scratch on the back of my hand, that is, an open, that's a wound. It's non-intact skin. So if you were doing hand and nail care on me and you saw a big scratch, would you need gloves?
Yes.
Okay. If you look at my hands now, would you need gloves?
No.
No. So for the test, you're going to have to make a judgment call. You're going to have to decide, do I need gloves? It's not based on the skill. It's based on the patient. So I can't tell you, no, you don't need gloves for this particular skill because I have no idea who your patient's going to be or what condition they're in. Good? Does that make sense? Okay, so we'll take a look. Do we need gloves? If they have open skin, yes. If they don't, no. Okay. Then we're going to get our barrier and get our supplies and put them on the barrier. Linens can't touch your uniform. You have to have clean hands to get those linens, and we don't want to snap or shake them. Then we're going to go get some water. We'll use a paper towel to turn the water on. We'll check it. And then who else has to check it?
The patient.
The patient. Once I'm happy that the patient has checked the water, we can start the skill. We're going to soak the hand in the basin. Then we're going to take it out of the basin and put it on a towel. You don't want it on the hard table. You want it on a soft surface. So we'll set it on a towel to wash it. Remember, we don't want suds in the water. We're going to take the hand out of the water, wet our washcloth, put some soap on the washcloth, and wash the hand. After we wash, we're going to rinse. So rinsing, I can use the rinsing washcloth, or I can put the hand back in the basin to rinse. I prefer that because it rinses it much better. So I'll take the hand, put it back in the basin to rinse. Take it out of the basin, put it back on the towel, and now I'm going to dry it. Once I have a clean hand, now remember, all of you guys are the patient for this. So chances are this is not going to be a hard skill, right? You guys all have pretty clean hands. You should, because you've been practicing. That means you've been washing your hands a bazillion times. So you should have clean hands. This part, not going to take long at all. Put the hand in the water, take it out to wash. Put it back into rinse, take it out to dry. There's not a whole lot going on here. Go through the motions, do the steps. But the hand isn't all that bad. Once we get all that done, we're going to clean underneath the nails. We're going to take an orange stick. An orange stick, some of you know it as a manicure stick. Oh. Come back. Yeah, there it is. Okay, this is an orange stick. This end is slanted. That's the one we want to use. This end is pointy. We don't use the pointy end. We use the slanted end. And we're going to use it like a scoop. So, Jake, can you, yeah, if you would. You guys see the slanted end there? Okay, so this slanted end is going to go up underneath the edge of the nail. We're not going to use this end. So if I were, come back here. If I were to use this slanted end on my own nails, I would slide it just underneath the edge of the nail, just like this, and circle it around, taking any debris out from under the nail. But now I got debris on that orange stick. Do I want to take that debris and put it under this nail? So I'm going to wipe it off on the towel before I move to this nail. Now we want to do this so that the bevel is up, not like this. We want the bevel up because we want to scoop. Good. Wipe that one, go underneath this one, circle it around, wipe that one, underneath this one, circle it around, wipe that one, underneath, circle it around, wipe that one. Good. Questions? Ooh, that's really close. All right. Once you've got the nails clean, we're going to file them. This is the step, the reason that you are doing this skill. This one. Washing the hand, that's important. Getting the debris out from under the nails, that's important. But this is why we're doing this. As CNAs, we do not use nail clippers. Nail clippers are advanced pieces of medical machinery you're not allowed to touch. The reason is that with a nail clipper, it's really easy to clip the skin next to the nails if you're not paying close attention. And especially in diabetics, we're going to learn about this later on. In diabetics, that wound may never heal, ever. So if you file the nails on a regular basis, remember we talked about this, the changes of skin earlier, right? Well, one of the other changes that happens as we age is with our nails. They don't grow as fast. So the growth slows down. The nails get thicker, a little more brittle. So we're going to file the nails to keep them at that manageable length. If you file the nails once or twice a week, you'll never have to trim them, which is ultimately much safer for the patient. That's why we do hand and nail care. It's to keep the nails at a manageable length. But we don't use this nail file. Everybody in here knows how to use the nail file. I know. But we don't use the nail file the way we use the nail file. And that's because our nails get more brittle as we age. If I take this nail file on my nail, I'm going to do this, right? Back and forth really fast. Well, what that does on your nails is file the nails. What it does on brittle nails is it pushes and pulls that nail just like this. Well, the center of that nail, as you're pushing and pulling, that center can break. It's called longitudinal stress, and it will split right down the middle. I've got a nail that actually does that. It'll split right down the middle. And when I say right down the middle, I'm talking all the way to the cuticle, and it will fall off. It's horribly painful for your patient. So we don't want to put that kind of stress on the nails because they're brittle. Instead, you're going to take your emery board and you're going to go in one direction toward the center, not back and forth, one direction toward the center. And that keeps us from putting that longitudinal stress, pushing and pulling that nail. So one direction toward the center. And then for the center, you just go right across to get that point shaved off. Good? Then move to the next one. Questions on orange sticks and emery boards? Questions? All right. Once you've done that, we're going to put some lotion on. Lotion is always last. So we're going to warm the lotion up in our hands. Don't put cold lotion directly on the skin. Warm it in your hands. Now, if you watch videos online, a lot of videos will tell you to put the lotion bottle in the water. And you can, there's no problem with that per se. I have a problem, but you can do that for the test. Here's the problem. There's three problems. Number one, you're introducing pathogens to the water, and I just don't think that's a good idea. But marginal. That's not a huge thing. The second problem is probably more accurate. That water is just lukewarm. Remember, it's not hot. It's just warm. And when you squeeze a lotion bottle, you're actually squeezing from the middle of the lotion, not the edges. So when you put that lotion bottle in the warm water, it's not hot enough to penetrate all the way to the middle. It's barely getting the outside edge of the lotion. So when you squirt that lotion onto the patient's skin, it's still cold. So putting lotion bottles in water to warm them up is not effective. You need to use your hands. Does that make sense? Good. Okay. So warm the lotion up in your hands, rub it on the skin, and then wipe off the excess with the towel. That's it. That's the skill. So then we have to clean up our area. So our linens go into dirty linen. Our basin is going to get cleaned using the basin cleaning we just talked about. Put it back in your drawer with your soap and your lotion. Make sure your table is clean by throwing away the barrier. And then do your closing. Thank you very much, Miss Jones. Is there anything else I can get for you? So the skill itself, not hard. Remember, they're giving us 11 minutes to do this. And we're doing our opening. We're washing our hands. We're getting our barrier and our supplies. We're getting our water, letting the patient check it. We're putting their hand in the basin to soak, taking it out to wash, putting it back to rinse, taking it out to dry, cleaning under the nails, and we're only doing one hand. Filing, one hand. Lotion, one hand. And then cleaning up and doing our closing. So this does not take 11 minutes. It might, maybe, take 5, 6. Don't rush. You've got all the time in the world here. Don't rush. When you rush, you make mistakes.
Just do your own pace.
Slow down. That's right. Go ahead, Jake. Okay, so we're going to place our dirty linens in our hamper. Never put dirty anything on the floor, by the way. We're going to clean our basin. And then we're going to do our closing. That's the whole skill. Any questions on hand and nail care? Please remember that this care plan is for this patient, not that one, this one. So our care plan, one more time, says provide hand and nail care to one hand. The patient is sitting in a chair at the bedside and can move as directed. So I, right here, would be the patient, just like this. Good? Questions? Let me show you this video. It's got good close-ups. This is the one I'm actually working on, the new video. This is the one I started editing this weekend. So I don't have the new one for you ready yet, but the old one will work. You got it? Oh.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place a barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
please.
okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. We're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. Okay, any questions on that one? Any questions? No? Okay. There's two. I used one, I wet it and put soap on it and then washed the hand, set that aside. And then when I put the hand in the basin to rinse, I used the second one just to squeeze water over to rinse. Yeah, but the second one was in the basin, so you may not have seen it. Okay. So what we've gone over so far, if you're looking at your syllabus, is we've covered hand and nail care. We learned washing basics, basin rules, linen rules. And we're going to move on to occupied bed now. And with occupied bed, this is making a bed with somebody already in it. Now, I can make a bed a whole lot quicker if there's nobody in the bed. If I'm just making this bed with nobody in it, it takes me less than 2 minutes to put new sheets on. Easy peasy. But if there's a body in the bed, that complicates the issue. It takes a lot longer to do this with somebody in the bed. Now, the test is going to give us up to 14 minutes to change a bed with a body. It doesn't take that long, but the test is going to give you up to 14 minutes. However, in a clinical setting, if I walk by a bed and it happens to be empty, I always think to myself, do those sheets need to be changed? Because remember, I can change an unoccupied bed a whole lot quicker and easier than changing a bed with somebody in it. So if my patient is out of bed having a test done or being transported somewhere or in the shower room, that's a great time for those sheets to be changed where we're not putting all this additional stress on the patient. Make sense? Okay. So as CNAs, we have to know how to change a bed with somebody in it. But remember, we're always looking for ways to avoid changing a bed with somebody in it. This is a pretty neat party trick, though. Pretty neat party trick. Now, the principles, as you can see on page 141, the principles down the side there. Let me move my chair. The principles down the side there tell us how to do this skill. These are the steps, the principles that are required. They're all spelled out for us here. We're going to follow the care plan. We're going to do our opening, evaluate if we need gloves. We'll use a barrier for our supplies. Our patient will be uncovered, so we're going to use that privacy blanket. Linen rules, we're going to kind of cover this a little bit more. We're going to learn scoot and roll, and then we already know the closing. We know most of linen rules, but there's two that we skipped, so we're going to go back and cover those now. Down here, you can see your test-specific information. Somebody with your level of experience should be able to do this in 14 minutes or less. It's going to be a live patient, so that means that you might be the patient for this in the bed. That person will be laying in bed, obviously, because we're changing the sheets. Documentation is not required for this one. So page 142 has our step-by-step instructions. If you take this book home and you ask somebody to read these steps to you and you do them, you will do this skill absolutely perfectly. This checks off every single one of those checkpoints that you're being graded on. And I'm very detailed. I tell you what to do first, what to do next. Nothing here should be ambiguous at all for you. Down here are your supplies. And care plan is at the top of the page. But we'll go to the next page so we can see the care plan a little easier. So here's our care plan. Care plan tells us to change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. Resident can roll and move as directed. So I can ask them, can you scoot toward me? Can you roll? They can do all of that. Care plan says they can, but they cannot get out of bed. Whatever reason, they can't get up. It goes on to tell us a bedspread, blanket, draw sheet, or underpad is not required for this skill. So top sheet, bottom sheet, pillowcase. That's it. That's all we're doing here. That's it. They can't make this any easier. Top sheet, bottom sheet, pillowcase. That's it. Here's our skill-specific steps we're going to get into in just a minute, but let's focus on the areas that we don't already know. Go ahead. You did good, Jake. All right, so on linen rolls, there's two things that we skip. So let's go over those first. One of the ones that we skipped is clean rolls toward me, dirty rolls away. And let me explain to you why this works and how it works. Yeah, probably. Yes, please. Okay, so let's say that I have a sheet on my bed. So this is my bed, this is my sheet. And this is my patient laying on the bed. Everybody got that visual?
Yes.
Okay. Now, if I want to change this sheet, I'm going to use a rhyme or a mnemonic to help me with this. Clean rolls toward me, dirty rolls away. So this sheet on the bed right now is a dirty sheet. So which way does it have to roll? Away. So I'm going to roll this sheet away from me. And I'm going to tuck it underneath this patient. That patient's just going to kind of hold that roll in place. Okay. Then I'm going to take the clean sheet, clean rolls toward me. So I'm going to roll the clean sheet toward me. Good? Okay. So now this dirty sheet, because I rolled it away from me, what's facing up is the underside of the sheet, the part that did not touch the patient. The clean sheet, because I rolled it toward me, what's facing up is the underside of the sheet. What's not going to touch the patient. So I'm going to put this roll underneath this roll, have the patient roll over it. So now the patient's holding it in place. And then I'm going to go around to the other side of the bed, and I'm going to remove that dirty sheet and unroll the clean one and attach it to the corners of the mattress. Good? So the way this works is clean rolls toward me, dirty rolls away. But a lot of students will ask, okay, well, hold on. What if, go back here. What if this sheet is wet? What if it's dirty? What if it soaked through and it's now on the underside? Well, then we would take a chucks. You guys remember these barriers? We would take a chucks and we would roll it, cover it, right? I'm going to cover that with the chucks before I put my dirty one or my clean one under the dirty. That just protects this clean sheet from getting the wet on it right away. But before I did that, I'd want to wipe off that mattress. Good. But our care plan for our test says we don't have to worry about all that. We're changing a clean, dry sheet with another clean, dry sheet. They're making this so easy for us. Not complex at all. Good? Do you guys understand what to do if the sheet is wet? Good? Okay. All right. Go ahead, Jake. Nothing touches the floor. Not clean, not dirty, nothing. Nothing touches the floor. So when I'm done with that sheet, when I take the sheet off the bed at home, where does my sheet go? On the floor. I take sheets off the bed, throw them on the floor. I put the new sheets on, then I bundle up the dirty sheets, take them to the laundry room and run them through the washer. It's what we do at home. We do not do that in a clinical setting. Nothing goes on the floor ever. So this is a change for us, compared to what we do at home. And it's important that you understand that. Anything that you put on the floor is going to spread pathogens on the floor, and the patient could potentially walk through that. We will walk through that and take those pathogens all over our facility and home with us at the end of the day. We don't want that. So nothing touches the floor, not clean, not dirty. But that's a problem because in a clinical setting, we don't have hampers in the room. We don't like to keep dirty things in our clean patient environments. Remember, we're all about clean. So if I can't put them on the floor and I don't have a hamper in the room, what in the world am I supposed to do with these things when I take them off the bed? Go ahead, Jake. This is what we're going to do. There are hampers. They're usually out in the hallway. We generally don't bring them into the room, but you can if you need to. They are on wheels. They do travel. But instead of using this is kind of last-ditch effort for me. I don't like bringing things into a room that I'm going to take out of a room because, again, that whole pathogen transfer problem. So I don't like using this. I have before if I need to, but I don't like this option. This is a better option. In your utility rooms, we're going to talk about utility rooms in a minute. There's a clean utility room, there's a soiled utility room. And one of those utility rooms, you're going to have a roll of bags that look like trash bags. And most of the time, they're light blue, stamped with soiled linen on them. These bags, you just tear one off and you take it to the room, you open it up, and you put your dirty linens right in the bag. Now they're not on the floor. This works well. Let me tell you about these bags. How many of you guys are familiar with Tide Pods? Okay. These bags are the original Tide Pods. They've been around for 40 years. The soap is actually in the bag, the plastic. That plastic, just like Tide Pods, you put them in the washing machine and they dissolve, right? They look like plastic, but they dissolve and there's no plastic in there when you get the laundry out. That's what this is. This whole bag goes into the washing machine and becomes the soap. The bag will disintegrate. It will dissolve completely. The problem with that is anything that's inside this bag will also go into the washing machine. So hearing aids, dentures, earrings, cell phones, everything that you don't check the sheets for will end up in that bag and ultimately in the washer and the dryer. So because we don't check these sheets, we don't pull the sheets out and shake them out to make sure there's nothing in there that can't be washed. It's our responsibility to make sure that whatever goes into this bag will survive a trip through the washer and dryer. If for some reason you end up washing a patient's hearing aid, the facility has to replace it. If you wash their dentures, the facility has to replace them. What do you think that's going to do to your raise? Yeah. There's no money for raises now. Dentures, about $5,000. Hearing aids, about $4,000, 3 to 4. They're expensive. So we've got to be really, really aware of what we're doing. Now, if for some reason you can't find your soiled linen bags, you can put a Chucks on the floor as a barrier. It does work. Just make sure those sheets don't overlap and touch the floor. This is preferred. This is okay. That last resort. Good? Questions? Now for the test. You're not going to have any of that. For the test, you will have a basket, a laundry basket, usually at the foot of the bed or like over here. It'll be within reach of the bed. They're going to make it super easy for you. They're not asking you to open anything. Basically, it's a basket. They're making it easy. The test is all about making it easy. Okay? And they'll point it out. If you get this skill, they'll actually tell you that's where your dirty linens go. Good? So this is what a soiled utility room would look like. In every clinical setting, you've got one, what we call dirty room, one clean room. Dirty things go in the dirty room. Clean things never, ever, ever go in the dirty room. Dirty things never, ever, ever go in a clean room. We got to be careful there. These things do not mix. But in your soiled utility room, you usually will have a red box. You'll have a red sharps container. You'll have usually a linen hamper, a sink. And then you'll have something that looks like a toilet, but it's not. In most cases, these are actually kind of square bowls rather than round ones. This is, the term for this is a hopper. I don't know why. I have no idea why. But they call it a hopper. If we have sheets that have solid waste products on them, we don't want to put those solid waste products into a washer. That's just kind of gross. So we use a hopper, which sprays water. It, like I said, kind of looks like a toilet. It functions like a toilet. But we can put a big sheet in there and use the water to rinse out that solid waste. And it flushes like a toilet. So it will take that solid waste away. And then we can put that wet sheet into our soiled bag. Good. Not all places have these, but most long-term care settings do. Okay. So remember, we've learned this. Linens, you use it or you lose it. So if you take too many, Remember that you're going to have to put them in dirty linen. Don't keep them for later. Okay. So that's everything you need to know about linen rolls. Now we're going to just touch on another principle. We're not learning the whole thing. We're just going to touch on it, called scoot and roll. And that's because the biggest thing I want you to remember about this, and we're going to cover this in detail next class. But the one thing I want you to remember about this is your patient must be in the middle of the bed at all times, period. That is the safest place for your patient. Go ahead, Jake. We can't rely on side rails to keep our patients safe. Side rails do not make your patient safe. In fact, side rails ultimately make your patient weaker. Side rails will make your patient degrade. In healthcare, we tend to think of, well, if our patient is a fall risk, if they're weak, I don't want them up wandering around because they might fall. So I'm going to put them in bed and put their side rails up to keep them from falling. But even though you prevented them from falling, did you do anything to improve their strength or balance or coordination? No. And you put a patient in bed for 3 days with side rails up and don't get them up and walk them, you can actually make that patient bedbound for the rest of their lives. They may not ever overcome that. Long-term care sees this a lot. Send patients to the hospital. Patient was ambulatory before they went to the hospital. They come back, they're bedbound because the hospital did not want them up walking around. That is a whole lot of power for us to have. We are affecting this patient's life. And we got to get smarter about this. So side rails restrict a patient from getting out of bed, which ultimately makes them a restraint. Absolutely. Now, there is a difference between side rails and positioning rails. Go ahead, Jake. Side rails actually function like a crib. When you were a kid, a baby, they put you in a crib because it was safe, but eventually you started climbing out of that crib. Is that safe anymore? No, mom took you out of the crib, put you in a little bed super close to the ground, toddler bed, and you learned how to sleep in a bed. This is the normal progression. Tall bars do not keep anybody safe if they're determined to climb out of them. Tall bars do not keep anybody safe if they're determined to climb out of them. All we've done is created a higher obstacle for them to go over. And side rails ultimately kill over 200 people a year. They get pinned, that's right. We're going to talk about that next class. Go ahead. So you don't need side rails to keep our patients safe. As long as they're in the middle of the bed, they're safe. And that's because of something called spatial awareness, which we're going to be talking about in the next class. But your patient is safe in the middle of the bed. We don't need side rails to keep them there. Oh, here, this will show you how they get pinned. Patients that are trying to get out of bed will often get body parts caught in the side rail components. And this is called impingement. This is deadly because it compresses. And this is how most patients that are killed by side rails are found. Can you imagine walking in a room and seeing that? Mm-hmm. Yep. Yeah. They tried to get out of bed. We created an obstacle. So side rails are not to be used for convenience. They're not to be used for safety. They're only to be used with a doctor's order. Only. We can't even trust nurses. This is how bad this is. We can't even trust nurses. Nurses cannot give an order for side rails. They're not allowed. And if we call a doctor and say, hey, we need a side rail order, that doctor has to physically come in and eyeball that patient within 4 hours of giving me the order. So if I call a doc at 11 o'clock at night and say, I need a side rail order, he's not going to give me one because he's got to come in and physically eyeball that patient before 4 a.m. So we got to figure something else out. Okay. We can't use side rails for safety. They don't improve the patient's outcome. Now, there's a difference between a full rail and a half rail. This half rail does not prevent this patient from getting out. This is not a side rail. This is a positioning rail. This allows the patient to maneuver in bed. This is okay. But if I put this one up, that changes the game. So in most settings, you're not even going to have this on the bed anymore. They take these off. So if I get an order as a nurse for side rails, I have to call maintenance and tell them to come put the side rails on the bed. So just be aware of what side rails are, what they aren't, but they are not for safety. Okay. So if we know we can't use side rails and there won't be any side rails for the test, go ahead, Jake. Go ahead. We just have to make sure the patient's in the middle of the bed. That's all it takes. And you do this automatically without even thinking about it. If I asked one of you to come lay down in this bed, you would put yourself in the middle of the bed. It's just natural. You wouldn't even think about it. You would just get in the middle because your brain knows that's the safest place for you. We do this subconsciously. Your patient will do it subconsciously. But if you put that patient near the edge of the bed, they're going to feel uncomfortable because their body does this subconsciously. Make sense? So if we are going to turn a patient onto their side, you want to scoot them toward you so that after the turn, they're in the middle of the bed. We don't need side rails. We can make sure they're in the middle of the bed. It just takes one extra step. Scoot toward me and then roll away. Always roll a patient facing away from you. Go ahead, Jake. Go ahead. Scoot toward me and then go ahead. Roll away. You want the patient facing away from you. Number one, weight distribution. Most of our weight is in our shoulders, lower back, hips, and butt. So gravity will always try to pull the patient back onto their back. It's just that's a physical principle. Gravity will pull the patient backwards. If I turn the patient toward me, that means gravity is trying to pull them away from me. I won't be able to stop that. I'm in the wrong position. I'll probably fall on the patient. So you want to turn them away from you where you're on the same side as the weight distribution, and that way you can prevent them from rolling backwards should gravity intervene. The other reason you don't want to turn somebody towards you, there's no easy way to say this, but you never want your patient to be eye level with your crotch. It's that simple. You turn a patient towards you, that's exactly what you're doing. You're putting your crotch, think about body mechanics here, guys. You're putting your crotch front and center, and that's not comfortable.